Thanks, David and Claudia, both for inviting me. I'm the mobile guy, and just prior to Vicky giving her talk, I've been negotiating with her about driving the mobile bus around Bristol Speedway. I can't think of a better imagery to drive attention to our program. So David wanted me to talk about screening efficiencies as it relates to mobile screening, some of the roadblocks and barriers that we've had along this journey. We're 8 years now into it. And I'll say that our biggest, I'd say, challenges in the C-suite when you're making your point about starting a mobile program. For us, they saw it as a disruptive, um, 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 or maybe a parallel type entity. We're just duplicating services. What I tried to convince them of, and it's played out in similar scenarios in different C-suites and different hospitals across the country as I've helped others, is they don't understand that our healthcare system is based on symptomatic patients who will tolerate a lot of inefficiencies. When you're asymptomatic, our symptomatic healthcare system doesn't respond to them and deliver their needs. And we didn't start this journey by saying we need a mobile bus, but as I walk out of the C-suite's office and it's almost like Groundhog Day across the country to help others, I reminded myself of Clayton Christensen, who is a Harvard business professor who wrote a book, The Innovator's Dilemma, who had this comment about that.
The reason why it is so difficult for existing firms to capitalize on disruptive innovations is that their processes and their business model make those innovations seem unattractive.
My journey really started about 10 years prior to today, where I gave a talk at a TEDx event, and I was talking about whether we could ever get to predicting diseases like cancer like we do the weather. The basis for that was my father-in-law is from Mississippi, farmer, always had a farmer's almanac, and would look at weather trends to decide when to plant crops, harvest crops, look at what's coming up. And surprisingly, with just humans doing this data analysis, they're about 85% accurate. I thought, what could we do with modern tools and technologies? My godsons were at the University of Kentucky, and they were telling me about not only how to make bourbon, but tools that were cutting edge as far as my knowledge, but were the front building blocks of AI, natural language programming, which was how computers understand our language, the intent of what we're meaning to, and can carry out a task. Machine learning was a way of how it continues to get better. We could also take an end result like somebody got lung cancer and work backwards and try to find some associations that weren't visible to us. So within that, my thought was we could identify with our own electronic health records people who are at risk for lung cancer, notify them through text messaging, a portal app, get them in to get screened. And the hospital was scared to death of me doing that. So we backed off and said, but I know when they're coming into their primary care doctor. I know when their next visit is. So we go around to our primary care network and hand them a list of all the patients coming in that week who qualified for lung screening. They were surprised at how we got that information. But I was more surprised how few we executed on getting the scan done. We looked at the orders are being placed, but we had a large number of people who would register at the imaging center and walk out, just like you'd have in the emergency room. And when I got to trying to identify the problems, I think we had two basic issues that still plague us today. One of it's the messaging problem. When I travel around, including this morning as flying into New York, I'll ask people sitting next to me on the airplane or Uber driver or somebody at the hotel, do you know anything about lung screening? I've yet in 8 years to have anybody tell me that they know what lung screening is. So we still have a large gap to fill. So that was one of our issues in our community. The other was the listening problem. People who are asymptomatic, who are 50 to 60 years old, who are managing their busy personal lives, they're maybe taking care of their parents, they've got kids, they're not going to give you much time. We tried to figure out how much time would they give us. Turns out it's the equivalency of a waiting in line for a fast food meal, 7 minutes. There's no way I could do 7-minute lung screening in the current healthcare system and get people to buy into that. So I designed a parallel system for asymptomatic patients, which was the mobile bus. One, I wanted to create visibility and attention with the messaging piece, and then try to create a 7-minute visit. The first prototype we built helped with the messaging, but our timing on the 7-minute visit, it wasn't designed for good throughput. So we redesigned it based on that. And here's where we are after 8 years of doing it. We've had more success than we thought. We've had over 11,000 scans. Surprisingly, we're now doing almost a quarter of the people getting on the bus are asking for coronary calcium scores. And that's not without any marketing, basically showing I think there's a a thirst or a hunger for people wanting to know about their bodies and take charge of their bodies. We are able to scan. We've done it multiple occasions, 50 people in a 6-hour window. The inefficiency of mobile screening is you have to drive somewhere, calibrate the machine, set up, then start screening, and then take it all down, drive back, and unload. But that's 7 minutes per patient consistently for 6 hours. Some of the inefficiencies of screening is how do we get the scans back to the PAC system and the radiologist? Initially, we're using cell towers, which didn't work very well, and we had dumped 50 scans on the radiology department. That took one radiologist a full day to read those scans. So in their workflow, the inefficiencies of reading these scans and all the data on it was part of the problem. As we got to changing and technology, keeping up with us, Starlink became one of the solutions for that. We look at last year's number, which is what the hospital constantly looks at, is the expense side of the balance sheet. It was $1 million to operate this mobile unit. Most of it was salary, wages, and benefits, because it takes a large number of human beings to operate a screening program. And I think it's whether it's a mobile program or a fixed-base program, the more successful you are, currently it takes a lot of people, not only to get the results back to them, but get them back in there for the annual scans. So our volume has really outgrown our innovation. We actually have a second bus we have parked in the garage, and I haven't let it get out on the street because the hospital hasn't committed to the appropriate staffing levels, and we're negotiating on that piece of it. So although the selling point at the very beginning of this journey was the C-suite, I have a different CEO now. It's the third different CEO who I have to convince again to spend the money to invest in personnel to take care of it. We're constantly in challenge for CT techs. There's a 19% vacancy rate across the country. Automating that process would help that piece of the equation. We have one CT tech currently. The second one just took another job. So we have to use available or volunteers from the hospital pool. And if we don't get that, then we have to shut down the program if our one tech is on vacation. We have the bus. To the success of it, will people get on the bus? Will they embrace a 7-minute visit? Our bus is booked out a year in advance, and that's a 5 days a week schedule. We proposed going to a 6-day a week and extending the hours so we could screen longer than 6 hours at a place, but it required hiring more personnel. And we thought that would get our numbers up from 3,200 per year on the bus to 4,500. My concern is that as volume has grown, getting people back in who need to get screened on an annual basis, trying to make sure they didn't get a scan 6 months ago in an ER somewhere else, and finding them a spot on the bus to get scanned. Our compliance has dropped from 70%, which we were proud of, to about 60%. And it's simply we're running out of the human capital to run the program and manage this. It gets very difficult. We have a constant backlog of 150 scans per day. We may have our registrars calling, and they may knock 40 of those scans off today. They come in tomorrow, it's back up to 150. So I think the purpose of, if you make something that's designed around an asymptomatic patient, where it's a mobile bus or some other fixed-base system, and you get the messaging out there, people will engage, but they're not going to do it until we accomplish both of those. Last point, as far as efficiencies and getting results to them, we had a goal of everybody gets same-day results. We're now running into radiology shortage issues. And reading these scans are difficult, particularly with all the data that's on it. Everyone gets a calcium score. There's a lot of work that has to go into it. They're prioritizing people in the hospital. Our stat reads above screening exams, and we have sometimes as long as a 5-day delay in getting our results back to people. But in general, I think most people, including myself, have been surprised that people will adopt lung screening. We just have to come up with a different way of them engaging in healthcare. Along the journey, there's been lots of scenarios where you could find fault. There's lots of criticism how we didn't do things right. But when you believe in something and you're seeing what we saw on our side, that people were embracing it, then it certainly keeps you going. Henry Ford was not known for inventing the car, because he didn't invent the car, but he invented the assembly line that made the car accessible and affordable to everybody who wanted one. I think all of us here are trying to do that with low-dose CT scan and getting people the health data they need to manage their lives. And I think they're ready for it. This was one of his quotes that he was famous for saying.
Don't find fault, find a remedy. If you think you can do a thing or think you can't do a thing, you're right.
I think all of us here know that we can do that thing, and we just got to persevere. Thank you.